Hey guys. So I made a boo-boo. I thought I had 10 minutes for this talk. It's five, so I apologize if I go over a little bit. Um, but spin off of Murillo, so we do so I do shoulder replacements and we're doing those at the surgery center. So it's a huge patient satisfier. Like patients love outpatient total joints and have had a really good experience doing those even at the Roanoke Ambulatory Surgery Center. So like outpatient total joints is where it's at. If it's appropriate for the patient, like medically, stuff like that, it's really nice to be able to do. Sorry, I feel like I'm leaning down. Okay, so I've been tasked to talk about ACL patient counseling, rehab expectations, timing of orthopedic referral in 5, not 10 minutes. Um, so just a few objectives here. So to recognize common ACL injury presentations, understand key counseling points. So for primary care docs, those in that setting, this is a huge thing. Reviewing rehab expectations and return to sport timelines. I don't know. That's kind of getting in the weeds for you. I don't know how much you're going to have to do that, but we'll give you some kind of general guidelines. And then just identifying indications and timing for an orthopedic referral and optimizing early management. Keep hitting the wrong button. Sorry. So again, common presentation is usually a non-contact pivoting injury. So if you get a young athlete that says they were run down the soccer field and they went to turn and they felt a knee pop and they collapsed and couldn't play, that's a very common ACL type injury and mechanism. So a lot of times they will perceive a pop in their knee and they will swell immediately. They will have a rapid effusion. That's usually blood in the joint. They will come with a quad avoidance gait where they don't want to straighten their leg out. It's a slightly flexed knee when they come limping into the office. And pain may be variable. Everybody has different pain tolerances, so it's not always severe, even though it can look like this. These are the radiographs. Again, just review AP, lateral, merchant are the three most important views to get for a knee. You can tell a lot from these views. An MRI really confirms the diagnosis and can identify other associated pathology. There's a lot that can go on in that knee when they sustain an ACL tear. And so it's very, very important to understand that when you're getting the MRI. An urgent MRI, I would say, is rarely needed. And we'll talk a little bit about that later on in the talk here. But it's not like if a patient comes in with a knee effusion, you have to play soccer, you immediately have to get an MRI. But you may have to. It's just something to think about. And then do not delay a referral solely to get an MRI. All right. Just if you have a high index of suspicion, do some conservative treatment, send them our way. We will take care of it. Rice principles apply to this. Weight bearing is tolerated with crutches if it is needed. Short-term bracing, not long-term. Please do not immobilize these people for like weeks before you see them back in the office. It will make them worse. They will become stiff very, very quickly. Early range of motion, quad activation is critical, and you can even get them started on physical therapy if desired. So key messages for patient counseling. So ACL tears are treatable and outcomes are generally pretty darn good. Not all patients require surgery. We'll touch on that in just a second. You can review some goals, age, activity level, instability symptoms that help guide treatment. Early rehab is essential, regardless of the operative decision. So early rehab is key, and recovery is measured in months, not weeks. So those that may succeed without surgery, so we call these copers. Who can cope with an ACL tear? I'll tell you, as our activity ages a little bit, more and more people in their elderly years, I would say, are becoming more active. And so this age kind of thing kind of changes, at least for me. I don't really look at the age so much as their activity level. Like we have 65-year-olds that are out there skiing triple black diamonds in Colorado, like for half the year. I mean, that's different than a 20-year-old gamer. You know what I mean? So like you got to kind of take everything into context. But if they are low demand, they have a non-pivoting lifestyle, meaning they just might go to the gym and, go for some hikes or go for some walk with their significant other, walk the dog, like stuff like that. Don't necessarily need an ACL reconstruction. If they have minimal instability symptoms, older, less active patients, those that are willing to modify their activities, and it requires dedicated rehab and monitoring. I should have added that you can actually compensate a lot of this with appropriate bracing as well. So some people will live in a brace and they'll be just fine. Who commonly benefits from a reconstruction? So young active individuals, those that are in pivoting and cutting sports, if they have recurrent instability episodes or they have instability episodes in a brace. So if you try to brace somebody and they just can't tolerate it and they keep having instability events, that is an indication most likely to have surgery. And then occupational demands that require knee stability. So rehab expectations. So early phase, Focus on swelling reduction. That will help them tremendously with their pain levels and for their range of motion. Progressive strengthening, both their quads and their hamstrings. Neuromuscular training and proprioception is essential, and that's why formal physical therapy is typically recommended. They can't do this stuff on their own. They need guidance with this stuff, and a PT referral is totally appropriate when it comes to this. And then just the patient adherence just strongly predicts outcomes. Like if you recommend this stuff, they don't do it, chances are they're probably not going to do well, and they probably won't do well with surgery either because they won't be compliant post-operatively. Typical recovery timeline. So this is kind of ACL recovery in a nutshell. This is typically with surgery. Usually for those people that decide to treat it non-operatively, they are usually back doing a lot of stuff by about 4 to 6 months in a brace if they can tolerate it. But with surgery, you're looking at 9 months minimum. Sometimes it can be a year. If you look at the NFL right now, most athletes are a year. But our patients are typically back at around that 9-month time frame, plus or minus bracing. But it is a very stepwise progression. People go at their own pace. I usually do counsel patients on that. Not everybody follows the same timeline. People recover differently, but in general, this is kind of what we see in ACL reconstruction. Common questions we get: can I walk on it? Yes. If it's stable and tolerated. If it just happened, you just got to make sure they don't have like a locked knee. You don't want them walking on a locked knee. Do I need surgery? It depends on your symptoms and your goals in life. How long until I return to sports? 9 to 12 months. Will arthritis develop? It really depends on the amount of instability episodes they've had, and then meniscal or cartilage injury at the time of the initial injury. So ACL tears don't cause arthritis. It's when ACL tears have cartilage-based injuries or meniscus-type injuries that then lead to arthritis down the road. And then can I delay surgery? And that just really depends on the pathology and the goals. You're not going to delay surgery in somebody that's got a locked bucket handle meniscus tear with the ACL, but you can certainly try to delay it if they want to try non-operative treatment, and you try physical therapy and you try to get them back to sport and see how they do. That's not inappropriate. I wouldn't do that for like an 18-year-old soccer player, but certainly if somebody has goals that are appropriate with that, you can try that. Sorry, I keep hitting the wrong button. When to refer urgently. So a locked knee is really key. I should have bolded that one. So that's really a big thing. So there's kind of a short list of orthopedic, we'll call it sports urgencies, and one of them is a locked knee. You don't want to leave somebody with a locked knee. Neurovascular compromise, very rare in the outpatient setting. That's more like ER type stuff. If they have gross instability, if you're doing a physical exam and their knee is just so sloppy, you pop them in a brace, send them our way. If they have fractures on their x-rays, certainly something to refer more on an urgent basis, and inability to bear weight. So timing, most, within days to weeks is okay. You can try some conservative stuff with patients. That's not inappropriate. You can see them back in a few weeks and see how they're doing. And if you have a higher index of suspicion at that time, that's appropriate. I mean, you might not get a good physical exam at the initial evaluation, but if their swelling goes down, the range of motion improves, you see them back in a few weeks and you can see that knee is loose, then you can send them our way. And then, yes, that's about it there. And then what you can do before the referral: just control pain and swelling, encourage motion, initiate PT if you think that's appropriate, and then counsel the patient and set realistic expectations regarding recovery timeline, just on the general stuff that if they ask you those questions, it's okay to kind of weigh in on that. And then we'll get more into the specifics once they see us. Pitfalls is over-relying on an MRI, delaying, a referral, a premature to pivoting sports. So just be careful doing that. Just make sure that they're ready, and make sure that, maybe the diagnosis may have been missed, or it's a different diagnosis and you try to return them to sports and they have an ACL tear when it wasn't initially picked up. That's kind of a boo-boo. And then the big one for us is prolonged immobilization. You'd be surprised how many times we see patients who've been in a knee immobilizer for like 4 weeks, and they see us in the office and they're just stiff as a board. So it's tough. So just some general take-home points. ACL injuries are common, and it's usually a clinical diagnosis. You don't really need an MRI. It just helps us to understand what else is going on in the knee with the MRI. Early counseling and rehab. Again, not every patient requires surgery. Instability does matter. Primary care physicians play a critical role in the early management, and a timely referral optimizes outcomes and patient expectations. Thank you. That's it.